Okay, we'll just give a wee bit of time for everyone to join. Okay, I think we'll make a start just now. Looking at the participants, I think everyone who was expecting to join has joined. I'm Ross Dolan. I'm one of the general and colorectal surgeons in Newcastle, and it's a real delight of mine to chair this monthly meeting of the Educational Society of the Cancer Cachexia Society. We'll run over a few things that are just going to come up in the next few months and highlight a few dates that you need to be aware of. And then I'll introduce my colleagues, Barry and Kristin, who will be giving us an excellent talk tonight, or today if you're elsewhere in the world. So the first thing to be aware of, our 8th Cachexia conference is happening in Turin in Italy in September. And there are a couple of deadlines coming up for poster presentations. The deadline is the 13th of June. So getting close just now, as is the case for the Scientific Images Contest. Both of those deadlines are the 13th of June. So if you have anything that you're wanting to put in, I would encourage you to do so sooner rather than later. This is an interesting one. Just a couple of days before the 13th of June, we're going to have our June webinar, and it's an interesting topic. It's looking at ways of identifying and treating childhood cancer cachexia, perhaps something that we don't see a terribly large amount of, but a very interesting topic nonetheless. And Daniel Runco is going to present that from Washington School of Medicine in the United States. I would encourage anyone to attend this. It will be certainly a very interesting talk. For tonight, my friends and colleagues, Professor Barry Laird and Dr. Kristin Solheim, are going to speak about the integrated, the MyPath study, which is an integrated nutritional care pathway and trying to incorporate nutritional care into routine cancer treatment using some digital platforms. Should be an interesting talk. And without further ado, I'll hand over to Barry and Kristin. So Barry, that's me. Stop sharing now. So you should be able to come. If there are any questions, please feel free to put them in the chat and I'll be able to ask them at the end. Okay. Thank you.
So Ross, is that okay coming up all right on the screen?
That looks fine to me.
Perfect. So thanks Ross for the introduction, and thanks everyone for attending wherever you are in the world and whatever time it is. And we're going to do a double act tonight, and Kristin and I are going to talk through this together. And as a brief overview of what we're going to do, most patients with cancer don't get good nutritional care, and we know that. And there's lots of reasons why we think that's the case, and there's lots of potential solutions to address this. So tonight we're going to talk a wee bit around this area and some potential challenges that we have, but also some one piece of work that we've been working on to try and improve that. And it's called the MyPath, Integrating Nutritional Care into Routine Cancer Treatment. So I'll pass over to Kristin, who's going to start off.
Thank you, Barry. Can you hear me well?
A bit louder, Kristin, maybe?
A bit louder, okay. I just recovered from a very sore throat, but I'll try to speak up. A lot of, or some of the things I will now present is maybe well known for many of you, but I think with today's theme, it's always good to have a repetition of the numbers and why nutritional care in cancer is important. So this is a slide with prevalence of malnutrition in patients with cancer. It affects approximately 20 to 70% of cancer patients, depending on their tumor type, tumor stage, and also their clinical setting. This shows from around 15% in breast cancer population until 60% in upper GI patients. Yeah, you can take the next slide, Barry. And also concomitant to that, we have the prevalence of systemic inflammation also differs between cancer site and stage, but that there is also a high prevalence of this. And this is from the Italian Premio study, where more than 50% of the patients had CRP levels greater than the upper normal limit for most cancer types except from breast. And also the same study showed a malnutrition prevalence of about 50%, either risk of malnutrition or already established malnutrition. Next, please, Barry. And a lot of the reason for why patients with cancer experience malnutrition are it can be different symptoms, either caused by the tumor location itself. It can be the metabolic switch related to cancer, and it can also be caused by the anti-cancer treatment. This is from a study with a large study with 1,000 cancer patients with different locations, where you find very high prevalence of several severe symptoms. And in the nutrition world, we call these the symptoms that also affect the patient's ability to eat or digest foods or absorb foods properly. We call nutrition impact symptoms. Yeah, then you can take the next one. So to either treat or prevent malnutrition, we need to address and manage these symptoms, the underlying causes of malnutrition. And at least it's important to reveal those we can do something about. And in that regard, we need to also be aware that research consistently show that us healthcare providers often underestimate the severity of the symptoms patients experience. So we don't actually know what's bothering them. We need to ask them systematically. Next, please, Barry. And so what do we know about nutritional interventions for cancer patients before and after treatment? We know that nutritional care is largely based on different healthcare choices, and there is no standard of care for nutritional interventions. There are also quite a few intervention studies, but they have mixed results and they have often very different populations and varying results. And we know also that screening for nutritional status and body composition is very inconsistently performed. There are very big variations also there. Some cancer centers are good at it, but other centers don't do it at all. And we have no agreed minimal screening questions or cutoffs. There exist several screening tools, several cutoffs, but there is no general agreement in the Cancer Society. And we also know that different malnutrition states, such as sarcopenia, is associated with treatment side effects, such as anti-cancer treatment toxicity. Next, please, Barry. And as mentioned, there is limited research on nutritional interventions in patients with cancer and malnutrition. And there doesn't exist any coherent intervention that is based on cancer type, cancer stage, or treatment. And also when and what to give pre-treatment is not clear. You have some centers doing different rehabilitation programs. You have ERAS guidelines for some surgical procedures, but there is no common ground for all this either. And since cancer patients are a heterogeneous group, what works for breast cancer patients doesn't necessarily work for patients with gastric cancer. And should maybe interventions be more tailored based on the patient's nutritional status, such as their skeletal muscle index or other measures.
Thanks, Kristin. So, you know, people who have heard me talk before know that this is one of my sort of favourite sort of paradigms to display that currently in modern oncology, we are really good. In fact, in the last 5 or 6 years, we've become phenomenally good at staging the tumour. We take patients, stay with a non-small cell lung cancer. We can stage them according to the mutation status, and based on that, they now go down a targeted treatment pathway based on that status. So it's very much bespoke therapy we're getting, and that's just lung cancer as an example. Breast cancer would be very similar. So we really have advanced dramatically with how we're staging the tumour, and that's been really a bedrock for treating the tumour and has resulted in the dramatic improvements in survival we've seen across cancers that were previously, hitherto cancers that had very poor prognosis. However, if you go to most, I would argue, most multidisciplinary team meetings and cancer centres around the world, we're generally notoriously bad at staging the host. By staging the host, what we usually do is look at their performance status, usually using the Eastern Cooperative Oncology Group status, and that's a measure of how functionally active somebody is, going from 0, which is fully active, which we all hopefully are, or down to 4, which is really in the latter stages of life and the last weeks of life probably. So we stage the host, but that can be done in a fairly ad hoc way, quite rudimentary, and it's not hugely accurate sometimes, because we know that patients often, when they come, are very keen to display a picture of them being in good health and good physical fitness, because they want to receive cancer treatment. And we also know as oncologists that we want to give treatment, we want to give cancer treatment. So those two aspects can meet and can result in sometimes patients who are potentially borderline performance status of getting cancer therapies, getting it and then having side effects. So really, in terms of staging the host, the condition of the patient, we're not very good at that. And certainly following on from that, we're really not as good at treating the host as we can be. There's been a lot of work and very on trend at the moment to talk about prehabilitation and rehabilitation. But a lot of that's based on dictum rather than any sort of strong evidence base. So I really think to optimally treat people with cancer, we need to complete this circle. Staging the tumour and staging the host or the patient. And then as we treat the tumour, we want to treat the host. Now, this staging the host, well, one area I think is key for this and Kristin's alluded to it during the earlier slides, is the nutritional status of the host. So can we nutritionally stage the host and then develop a nutritional treatment for the host? Well, we've got guidelines for this, which is fantastic. We've got the ESPN guidelines, which I was privileged to be part of. They're now cited probably over 5,000 times. And you've got the ASCO guidelines, which again are heavily cited guidelines. And you've got ESMO, which is cancer cachexia clinical practice guidelines. So these are just 3 examples of guidelines that are commonplace and highly cited in research literature in the area of cancer nutrition. Yet, most clinicians and healthcare professionals do not use these guidelines in their day-to-day practice. Some are not even aware of these guidelines, and if they're not even aware of them, how do they use them? They also vary quite a lot in terms of some aspects, readability being one, but also some of the technical aspects. But just to give you an example, the clinical nutrition ESPN guidelines, which is highly cited, and I'm biased because I was part of it. It's extremely long. It's about 30 pages with very, very detailed guidance on how to manage nutritional care in people with cancer, and they use different definitions of cachexia. Now, if we as cachexia researchers, can't agree on definitions, and they're complex and things, then how can we expect, jobbing oncologists and healthcare professionals who are, not as aware of the literature to pick up these complex aspects? So, there's a challenge here, and just to give you sort of some further evidence of how these guidelines can be helpful but unhelpful. So my computers have stopped a minute here. Sorry, there we go. So this is just giving an example of some of the differences in these guidelines. So the ESPN one looks at both adults with cancer and cancer survivors, whereas ESMO and ASCO looks at patients with cancer cachexia or patients with advanced cancer. Some cover screening, assessment, and management. Some just cover management. So, for example, ASCO just covers management. For terms of screening and assessment, well, the ESPN and the ESMO guidelines are fairly aligned in terms of their nutritional screening and assessment and interventions. But the ASCO guidelines don't specify specific nutritional screening and assessment, and do offer some advice on nutritional interventions, but they're different. They're differing. And then when you get to other interventions, these differ too. So not only have we got 3 guidelines, commonplace, I'm just using these as examples to highlight I think the problem that we have, that they're potentially not that user friendly, not that clear, and they're potentially contradictory in what we do. So I think we've got a bit of a challenge here, because we've already highlighted that nutritional care in cancer is often not managed well, and then we produce guidelines to try and fix that then potentially cloud things and make it more complicated for us to do it. So there's disparities in this, how they're screening and assessment versus management, general recommendations versus tailored recommendations, and different definitions and diagnostic criteria. So there's some issues here. There are some common grounds that they talk about: early screening, individualized interventions, monitoring, thinking about the stage of the disease of the patient. And they all underscore that nutrition is crucial in cancer care. And they all think that we should have, advice and recommendations in a unified approach for cancer. So it really is a challenging landscape just now with these, which are all very excellent, very well designed, well read guidelines. But if they're not being used, then you could argue, oh, what is the point? There's the GLIM group, so that's a global leadership initiative on malnutrition. they've got quite a strong criteria for their how they diagnose different degrees of malnutrition. So they go through a sort of screening approach, diagnostic, assessment, diagnosis, and then the severity grading. They would use validated screening tools, and to sort of have a diagnosis, they have quite strict criteria that you've got to have either one phenotypic criterion, such as weight loss, a low BMI, or a reduced muscle mass, and one etiologic criteria, such as reduced food intake or disease burden or interesting inflammatory condition. And GLIM actually define cancer cachexia as disease-related malnutrition plus inflammation. So they're acknowledging here that there's a strong sort of biological, systemic pathway behind this. And then based on all these things, we then put a severity. So how can we get these guidelines into our clinical practice? So I'll hand back over to Kristin for the next few slides.
Yeah, thank you, Barry. So what we now have presented for nutritional care, it's also the same for other components of patient-centered care, that you have guidelines, you have evidence, but it's not integrated into routine clinical practice. So that is the sort of the scope for the MyPath project, where the approach is a comprehensive integration of patient-centered care pathways based on guidelines and existing evidence into routine care. Next, please. Yeah, so MyPath, it's an EU project, as mentioned, aiming to implement patient-centered care at 9 different EU cancer centers using implementation science. It's a 5-year project. It started in September 2022, so we are more or less halfway into the project period. Next, please. So the main aim for the MyPath project is to assess whether patient-centered care can be integrated into clinical practice using patient-centered care pathways that is supported by health information technology. Yes. Next, please. Yeah, I think you can take the next one. I thought I had removed that one. Yes, thanks. So the different clinical steps in MyPath is that the patients are onboarded to the digital solution, where they then complete patient-reported outcomes via a patient application called MyPath Patient from their home before a scheduled consultation. And then before the clinicians have a consultation with the patient, they can review what the patient have reported in MyPath Clinician. And then during the clinical consultation, when the patient is then present together with the clinician, the digital solution will then guide the clinician through a clinical assessment. And then based on both the information that the patient has self-reported throughout the PROMS application and what the clinician registers during the clinical consultation, the patients will be classified. And then the clinician can tailor a patient-centered care pathway based on the patient's needs and also the patient's preferences. And these care options that the care plan consists of are then guideline-based care options. And then after the consultation, you will have a follow-up that can either be digital through this digital solution, or of course through a clinical consultation when needed. And within this project, the main areas of pathways developed through the MyPath project. You have pathways for pain and for distress, both emotional and social. And also you have the MyPath nutrition care pathway that me and Barry have been working on. We have a scientific group we have collaborated with from several of the different MyPath partners from different countries in Europe. And these consist of both clinicians and researchers. We have backgrounds as dietitians, oncologists, nurse. So we are a broad group with different kind of focus areas and expertise. And we've also had Jan Arends as who's also author of the Aspen guidelines that has been a valuable volunteer in our group. So the first we did when we started developing the nutrition care pathway was to select what kind of variables we needed to both assess the patient's nutritional status appropriately, and also what we would need to guide the different interventions or care options. So we then revised what different frequently used screening tools consist of, and also what is recommended in the Aspen guidelines for screening. And then you have the components: food intake, weight, height, BMI or other anthropometric measures, weight change, nutrition impact symptoms, or the different symptoms and side effects that also affect the patient's ability to eat or absorb or digest foods properly, muscle mass, performance status, and inflammation. And then we also did the same for the advanced assessment. If a patient is at risk, what else should we assess? Both what the Aspen guidelines recommend that we should assess, and what also these the GLIM diagnostic criteria for malnutrition that Barry mentioned, what they also recommend to be part of the an advanced assessment, and translated then these different components into the MyPath nutrition care pathway classification that Barry will show you a bit more in detail later. So then we chose what kind of items the patients could self-report through the PROMS application, and also then what kind of information we need to either retrieve from the electronic health record or should be part of the clinical assessment. Yeah, thanks, Barry. Take the next.
Thanks, Kristin. So what we'll try to do basically is take the good bits and the common themes of these well-written and evidence-based guidelines and pull them together in something that's quite user-friendly, as in user-friendly for the clinician. So when I go back, think about my earlier slide when I was talking about staging the host, we've really tried to do a thorough nutritional staging of the host. So PROMS, for anyone who's not aware of that term, it means patient-reported outcome measures. So these are things that patients tell you, almost like reporting symptoms. So the patients complete this electronically. This is also a software platform, and they complete things questioning the nutritional impact symptoms, because we know that pain, constipation, dysphagia, etc., these things, low mood, will all affect nutritional intake. We record their dietary intake, their weight history, so how much weight they've lost, and their current weight, as well as their height and their performance status. So we record all this information, and then that's what we give the baseline information, if you like. And then we can also include other aspects such as their age, their cancer diagnosis, their therapy plan, etc. And also we've included a C-reactive protein as one of the inflammatory biomarkers. So we're taking both information from the patient themselves, but also from the EHR, the electronic health record, and that all happens before patients have their clinical consult with the oncologist or their surgeon. So during that consultation, what they've reported was reviewed as a dietary intake, any interventions they're going through, also looking at their prognosis and any need for prehabilitation as well. And based on that, based on these patient information, electronic health record information, and also the clinical consultation, we then try to develop a nutritional classification of the patient. And we've basically thought of really three pillars of this. One is their nutritional status, one is their inflammatory status, and one is their health status. So for nutritional status, for example, they would be classified as either not at risk through to severe risk of malnutrition. Their dietary intake, well, how severe is it? What's the cause of it? And how long is it? So for example, somebody who's getting radiotherapy for a head and neck tumour, their cause of decreased dietary intake might be very different from somebody with, say, a pancreatic cancer. We also then will look at their inflammatory status, because we now know really that's a cornerstone of nutritional classification and staging. And they also we bring in their health status. That includes their performance status, their prognosis, and the need for rehabilitation. So we use all these to inform essentially a nutritional management plan. So we've tried to really take these foundations of concepts and parameters that we know are critical to nutritionally stage somebody, but put them in an easy to use application for clinicians, but also those is patient informed. So based on that classification, we've very much got a sort of stepwise approach here to how nutritional care. So, for example, all patients might get advice on physical activity and diet and general recommendations for activity. The presence or not of nutritional impact symptoms, these would need to be managed. They would get tailored dietary advice, and that then may include medical nutritional therapy such as oral, enteral, or parenteral nutrition. And that would be disease or treatment specific. For example, in pancreatic cancer, a clear thing would be creon use of enzyme replacement therapy and to screen for glucose intolerance, or prehabilitation dietary advice. So it very much produces a personalised management plan depending on the cancer stage. One of the things we've got in this, so with a sort of a clause where even if you score a low or a no risk of malnutrition, if you have a poor prognosis, cancer, or a cancer where we know that malnutrition is particularly problematic, such as lung or pancreatic cancer, you're automatically put in a high risk category, irrespective of your nutritional status, because if it's not, if patients are not nutritionally deficient at that point, we very much feel that they're going to be, so we treat them as that anyway. So let me give you an example of what this might look like in terms of the real world for a patient. Well, as a patient, look at a 75-year-old with pancreatic cancer and is on neoadjuvant therapy with a plan for surgery in 3 weeks with curative intent. So at the clinical consultation, their patient-reported outcome measures were assessed. They had decreased dietary intake, and that was due to nausea, and it wasn't expected to improve in the next few days. They were systemically inflamed with a CRP of 23 milligrams per deciliter, and they could potentially have invasive interventions and needed some rehabilitation prior to surgery. So they were classified as moderate malnutrition with decreased dietary intake. This was also informed by their problems, which showed that they had lost considerable amount of weight. They lost 5 kilograms, so over well over 5% of their body weight in the previous 6 months. Their BMI was 21.8 on the lower level of normal, and they had decreased dietary intakes at 75% of normal, with a degree of diarrhea and nausea, with a performance status of 1. So all this goes in together to give that patient some nutritional care options. So they had moderate malnutrition with inflammation. We had advice on diet, energy and protein-rich diet and to maintain or increase their physical activity. They had dietary advice from a counsellor or a dietitian. They had pancreatic enzyme replacement therapy and advice for prehabilitation to improve their physical activity prior to surgery. So this might look quite different if it was somebody with, say, a breast cancer who had metastatic disease but had it for many years, or somebody, for example, who had a head and neck cancer where it might more advise the route of using some form of enteral nutrition. So this just gives you an example of what it looks like in practice. We're in the process of about to start testing this with patients because we feel this really identifies a huge unmet need in that most, as we said in the earlier slide, most patients don't have malnutrition either identified or treated adequately. But we know that for patients, their diet, their loss of weight, the social context that goes around not being able to eat within their family environment is huge. So it's an area that's really important for our patients, and it facilitates discussions on these areas. We know that cancer therapies are likely to cause some degrees of certainly muscle loss, sarcopenia, but we know also conversely that patients who have malnutrition and cachexia do worse on their cancer therapies. The cancer therapies are less efficacious. So as well as this being a treatment to try and improve outcomes for patients, we hope that if we can improve nutritional status, we'll essentially improve the efficacy of cancer therapy. Our experience so far is patients find this really easy to use. They're really happy that people are asking them about their diet and their exercise. And they quite like symptom reporting. They don't see it as burdensome. But we need to now at the stage where we need to put this into clinical consultations and see how it works more in the real life across multiple centres. So I'll go back to my paradigm here about staging the tumour and staging the host. So we think that this MyPath nutritional care pathway certainly aims to meet the aspect of staging and treating the host in cancer. Now, there are other aspects such as pain, different pathways and things, but in oncology, nutrition is clearly evident and needs addressed. So this is one way we've thought of bringing these guidelines and these principles that are well researched and evidence-based to some extent into more of the clinical practice. So we take here, we've put alongside the cancer care pathway of suspicion, imaging, diagnosis, followed by treatment initiation, the staging of the patient. So nutritional, health, inflammatory status, classifying them, and then putting that care plan into action. And that really is what you see in the bottom half of the screen there, really speaks the language of oncologists in that we are staging, putting a quite a discrete stage on patients and then treating them according to that stage, which is what the basis of modern cancer therapy and cancer treatment is at the moment. Thank you.
Thanks, Barry. That was and Kristin, that was fantastic. Really interesting talk. Please feel free to put some questions in the chat in due course. I mean, I have a quick one initially, guys. The prehabilitation is an interesting form of treatment of the host. Do you make allowances for different sorts of prehabilitation regimes within the recording in MyPath, or because some can be more robust than others, obviously? Is that something that you make at least a note of when you're recording things?
I mean, yeah, great question, Ross. The ERAS program, you know this as a surgeon, it's well ahead of its time. It's an excellent program that is been well established and improved surgical outcomes and is highly adopted. So if patients go into that program, if that program exists in the hospital, we don't reinvent the wheel. They do that because that aspect is covered well. But if it's not, then we would aim to implement some principles of that.
Sure. I mean, have you just carried out some tests of I presume this is I'm sorry if I missed that, an app-based digital program, is it, or is it? do you give them their own wee little tablet or anything like that?
No, it's a good question. No, at the moment it's not an app. At the moment it's integrated into the healthcare system. So if you're sitting in a clinical consult room just now, Ross, this would be on your computer, on your screen, integrated into the healthcare record. And the tablet, the iPad they would use beforehand would provide that information for you. So it's an electronic questionnaire that feeds into a hospital system, and that's part of the challenge of this process, is actual integrating that technology into various healthcare systems across the world. That's where we're only doing it in a few centres initially to see if it works. And we're also about to do a sort of larger efficacy study to see, does this pathway actually improve outcomes, which we hope it does, but we don't know it does. So, so we don't know the guidelines improve outcomes. We think they will, but that needs to be done as well.
Yeah. I have to say, I quite like the way that the treatment runs in parallel with the cancer treatment, and in many ways brings the designer medicine into staging the host and not just the tumor. So I think that's excellent. I hope it yields good results, because I think it will. Once again, is there any questions from the group for?
I think there's a few on the chat, Ross. I can see a few on the chat.
Let's have a wee look. There we go. Excellent. Now, okay. Good question from Elena. Are there consistent studies on patient microbiome versus nutritional status?
Yeah,
just a wee question.
I mean, I can take this, Kristin, if you want. And Elena's been clearly listening with great intent, because she's got quite a few questions there. So I'm happy to take a few.
You've given quite a few questions, Elena. So we'll work through them.
So Elena, no, there's not. And the microbiome really is an area that still remains hugely, under research. I think we're just starting to really understand the whole basis of the microbiome. So that's what we don't know. We don't know that. And your question about Solheim et al. Consensual assessment. So are you asking there, Elena, do you think is the GLIM criteria agreed worldwide? If that's what you're asking, the answer is definitely no. If the question is, should it be? I think the answer is potentially yes, but we've seen here lots of different definitions of cachexia, malnutrition, different guidelines here, and they're all quite similar but not identical. So the Solheim approach, the GLIM approach, is just one way that they've tried to take both etiological factors and phenotypical factors, including sort of inflammatory status, to give some form of nutritional staging. So
good. And I think, Elena, we kind of answered the question about integration into national hospitals, and that will need to be run out over after the initial test period. Barry, would you agree that's a reasonable answer to that?
Yeah, absolutely. And then the admin, I see CC. Lisa, have you got a question you want to ask Lisa Lepowski? No, I'm just seeing something coming up.
There was a nice sort of link.
I'm just checking them off.
Sure. Oh, that's fine. Nice, thank you. That's okay. That's fine. Just checking.
There's a nice sort of linked question actually about a prebiotic or symbiotic, symbiotic treatments as part of the role of the microbiome. Barry, would you be able to?
I mean, Kristin, do you want? You're a dietitian. Have you got any comments on that one? Pre-probiotics versus symbiotics.
Yeah, and this far we don't have enough evidence, but I think that maybe in the future we will know more. But for now, there is no evidence or sufficient evidence that pre or probiotic is of any help. Yeah, but if there is in the future, it will of course be able to be implemented into the MyPath solution. Yeah, so that is sort of also part of how we are designing it, that it must be configurable. It must be able to adapt the content, both of the assessment and also, of course, the care options, aligned with what the future brings us in terms of evidence for if it's either assessment or management of malnutrition.
And thanks very much. And another question from Elena about application beyond the initial centres. I guess the answer to that is we're just starting to roll this out now, guys. Is that right? And then the next step would be if it proves
I mean,
applicable to roll out elsewhere.
Yeah, absolutely.
Okay.
And Elena, I think you made a comment about the healthcare systems in Spain being decentralized as well. So that's the challenge you've got here. You've got different healthcare systems, different, IT in different centres, different centres in different countries. So that's one of the challenges. I think the first thing we want to say is, can we implement it into some centres? And then if we can do that, sort of through implementation science, we can then see, could it be rolled out? And patient representatives are very much part of the project, and it's being tested with them as well. So that's a key point. I think the other thing is that, so I was going to say, Ross, sorry, that for
no, go ahead, Barry.
For certainly for companies who nutritional companies, we know that sometimes getting oral nutritional supplements can be a bit of a lottery, based on whether or not questions are asked and things. And it's certainly the case that not enough patients are likely to benefit from these. Same with seeing a dietitian. So even if this just leads to more patients being identified as nutritional risk and seeing dietitians and seeing getting nutritional supplements, it's got a massive impact. And we've had some really positive feedback from a group called the Medical Nutrition Industry, who are the sort of umbrella group of nutrition companies internationally who are very supportive of this.
Okay. An interesting question that's kind of close to my heart, I suppose, is should the determinants of sarcopenia using CT imaging be incorporated into the assessment of cachexia? I suppose that's it depends on disease type and workup, I guess. But do you guys want to have a wee chance of answering that?
Well, Ross, I was going to ask you to answer that one, because that's been one of your big areas of research. But I mean, I can maybe kick off. I mean, is it important?
Yeah,
yes,
it has been. I think. Go ahead. I mean, I
no,
personally think
it's important. It's important. We've not chosen to do that here because for most centres at the moment, it's a research-based tool, and we didn't want to overcomplicate it at the moment. I think if we're going to do it, we have to work out why we're doing it as well. One thing that's potentially of interest is how different treatments impact adversely, lean mass versus adipose tissue. And a really nice paper by Vera Mazurak's group in Canada recently showing that the two common regimes for metastatic pancreatic cancer have completely different effects on skeletal muscle versus adipose tissue muscle. So we need to better understand the interplay between these two, different therapies and how they influence muscle, lean mass, fat mass, and potentially both. Ross, any comments from you on that? Because this is obviously your area too.
It's a very insightful comment, Barry. I think in order just to, I think CT drive body composition is a good way of assessing cachexia, but as you say, there are marked differences in the way that this responds to specific treatments, and that is that could be a kind of a factor that would you want to not particularly include in an initial study where you're trying to make things as simple as possible to ensure clinical applicability. But I also think it does this does need to fit, Barry, as far as I can tell, into clinical pathways. And, you know, some people, for example, breast cancer patients won't get CT scans, you know, so there are these sort of things that you need to fit into the clinical pathway just now. I personally think it should be incorporated, particularly with the increased use of AI and the improvements in analysis using CT dry body composition over time as well, using multiple scans as opposed to just one, which can be a snapshot. But I do understand why it's not been incorporated into this particular study, is what I would say. Okay, I'll get some more. Oh, okay, here's a good one for Kristin. Great talk, it's from Gabrielle. Do you think that there is a nutritional intervention that is more effective than others? For example, is the Mediterranean diet better than ketogenic or low carb diets? And do you suggest monitoring a specific protein intake because of muscle loss? Couple of questions there.
Yes, thanks. Those are good questions.
Yes.
For now, it's not recommended to go extreme in any way for patients with cancer with risk of malnutrition. The most important is that they actually eat sufficient energy, and as you also mentioned, specifically protein. There you have, I think the guidelines now say from 1 to 1.5 grams of protein per kilogram of body weight per day. But I think that that might increase a bit when the guidelines are revised. But no, it's more, I would say, not encouraged to do any extreme diets because the risk of having a too narrow diet that you're not able to eat enough energy. So, yeah.
Okay, that's a good answer to that. Just another sort of wee observation I had is you are right that patients don't report a lot of their symptoms to the same extent to us directly. You know, I know, for example, that, you know, as part of the ERAS protocol, you want to encourage sleep in patients in an inpatient setting, and often that is terrible. And sometimes people just don't want to disappoint the doctor from time to time, and they just won't admit that. So I think it is quite a good thing to have this as an ability for people to answer that before they attend clinic. Do you impress upon them that, you know, that they for example, that this needs to be as truthful and as accurate as possible, and to maybe not have too much of a sunny outlook if they think a doctor's going to be looking at what they say? Is that what you say to them in the initial workup?
I think that at least my impression is that patients, when they can self-report in advance, they are honest, and they actually report how they are, and that then also the clinician don't need to ask all the questions if they ask, but then they can focus on what's actually bothering the patient. Yeah, so that is my impression, at least through this project, that what the patient self-report is the most accurate to the truth. Yeah.
No, I agree, and that's one of the things I wanted to raise. Margaret Parks answered an interesting question, close to my heart, I suppose, as a colorectal surgeon. But fantastic talk. Speaking of the microbiome, how would pre-surgical prep for example, for a colorectal resection, affect malnutrition and supportive nutritional guidelines post-surgery?
So that's a really good question, because obviously, patients having surgery will get a bowel prep and obviously oral antibiotics to try and reduce bacterial load, but then they this can then disrupt the gut microbiota, which then will, potentially get rid of, beneficial microbiomes. So this will basically affect the gut, leading to, reduced integrity, I guess, and increased inflammation. There's also then you will get because in the gut essentially is damaged, I would presume that you'll get impact on nutritional status, so reduced absorption of nutrients and maybe potentially worse GI symptoms, which also can persist post-op. So essentially, I think to try and mitigate this, Margaret, they're now trying to think of, well, can we give pre-habilitation to screen for malnutrition, give supplements pre-surgery, consider prebiotics, and then early post-op feeding where possible. And I think there's emerging evidence for sort of microbiome support, but that doesn't exist yet. So as we, in some ways, if we try to improve our, to mitigate some events using surgical prep, on the other hand, would potentially add making some nutritional outcomes worse. So that's a big area for work in the future. I think it's something the team in Maastricht are focusing on. So.
Margaret, there is a bit of variation in who gets PrEP depending on what side of the colon the cancer is located on as well. So, and that varies between different geographical locations as well. So, it's a very interesting area of research, and certainly something that also surgeons are very interested in, but it's quite heterogeneous as well. Okay, I think we've answered all the questions. I'll see if I've made any.
There's one just come in, Ross. One just come in.
There we are.
If there's time for one more, but maybe
we have the time. We have 3 minutes. A bit of praise for you guys, and then are there nutritional supplements for cancer patients that specifically aim to address issues of altered taste or texture that affect the desire and ability to eat? An interesting question there, Sarah. Thanks very much. Kristin, do you want to have a go at that?
Kristin, this is for you.
Yeah. I think. Yeah, I can try to answer that. It's a very good question. I think that most, at least different manufacturers of nutritional supplements here in Norway, or that supply Norway at least, do try to develop supplements that address this exact issue, because they have some quite, I would say, strange for us with normal taste, that there are some flavors that sound a bit strange for us, but that they do perform quite extensive testing in patients with altered taste. So you have, I would say yes, but it probably depends on what country you are in and what's available on the market there. But yeah, at least here in Norway, we have some different options for that.
And this is just a question from me. The texture of supplements is quite an important thing, I guess, for people. How do they test that? It's quite an interesting. I've never thought of it.
No, I think you have at least now also talking from the Norwegian market. We have different textures. If you think about patients with swallowing difficulties, maybe due to tumors in the upper GI or radiation. You have also some different alternatives for nutritional supplements with different textures, from the complete liquid ones until more like a pudding or thick yogurt texture, and then also some stages between there. And you also have different kinds of thickeners that you can add to liquid foods to create the consistency or the texture that the patients are able to ingest.
Yeah, good. I think that will, I suppose, allow people to continue to eat with their family, which is an important thing. So we have 1 minute left, probably about 30 seconds before we have to finish. I think we'll just call it a day in terms of the questions, etc. And listen, thanks very much to our speakers tonight, to Kristin and to Barry. Excellent talk, really interesting idea. Hope it works. I think it's an ideal, nice and simple idea that I think can have a big impact on patient care. So watch this space. Okay. As I said, I look forward to welcoming everybody for our talk in June. Again, I will be looking at cancer cachexia in pediatric patients. So an interesting topic moving forward. And finally, get your abstracts in for our conference, your poster and scientific images abstracts. Closing date is the 13th of June. You have been warned. Try and get them in. Okay. Guys, do you have anything more to add before we call it a day?
I was going to add that they have to be quick with the abstracts because we've had a lot in already, and if we're in like Edinburgh, we'll sell out. So, as we say in Scotland,
Yeah.
if you're not fast, you're last. So, get a move on with the abstracts. Thanks, Ross. Thanks,
Yes.
everybody.
Okay. Take care, everybody.
Bye.